Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. Welcome to Gyno Girl Presents Sex, Drugs, and Hormones. I am Dr. Smina Rahman. I am a board-certified OBGYN and sex med specialist and menopause specialist here in downtown Chicago, and I have been really enjoying this podcast. I hope you guys have as well, and please give me some star ratings and, like and subscribe to my podcast. I would love that. But today I had a really good conversation. You guys are in for a treat. I spoke to Dr. Becky Lynn, and she is a board-certified gynecologist in Missouri, and she owns her own private practice, concierge practice, Evora Health. And she's pretty amazing. Honestly, she and I are very similar in our journey into sex med and menopause and our history of academic medicine. But she talks a lot about all the ways that she helps her patients in her practice when it comes to sex med complaints. She also is obesity certified in obesity medicine. So we talk a lot about the GLP-1s. So you guys are going to have fun with this one. So let's get at it. Hey y'all, it's me, Dr. Smina Rahman, Gyno Girl. Welcome back to another episode of Gyno Girl Presents Sex, Drugs, and Hormones. I'm Dr. Smina Rahman. I'm here to educate so you can advocate for yourself. I'm here today with the amazing Dr. Becky Lynn. She is amazing clinician, sex med specialist, and menopause expert. So I'm super excited to have you here, Becky. As a background, Becky and I met through Ishwish in the past few years, but we also love traveling and going. And we actually always go to ISSM World Conferences together, which is the International Society for Sexual Medicine. And so we have a lot in common. We're both board certified gynecologists, sex med, and menopause people doing it in the Midwest. And we both have this academic affiliation, used to be in academics.
Yep.
So, but I'm so excited to have you here. Thank you for joining us today.
Yeah, thank you so much for having me. This is fantastic.
Yeah, and we both like to wear vibrant colors at conferences.
We do. I love your fashion sense.
we're both like, I like what you're wearing. No, I like what you're wearing.
Yep.
Anyway, so let's talk a little bit about. I love to ask all of my guests, especially for those of us, we don't get the training in school, we don't get the training in residency. 6% of people know how. 6% of graduating residents from multiple specialties know how to treat menopause.
Yep.
And probably, sex med is even, that or less. So Tell me, Becky, what brought you into sexual medicine, and then we'll talk about stuff. Eventually, we'll talk about your cannabis research and what brought you into that.
Okay. So I did my training at WashU, regular OBGYN, the basics. And after I finished, I went to a community hospital in Jefferson City, Missouri. And all of a sudden I was seeing patients who were asking me what to do with low libido. And I had nothing, no training on that. And I was like a deer caught in the headlights. I didn't know what to say. And this was a while ago. So it was before the internet. And I got in the mail one day a card about a conference about sexual medicine. And I was like, oh, I've got to sign myself up because sex is so important.
Right.
Kind of pushed under the rug. Oh, we don't talk about it. It's really important to have a healthy relationship. And so I went to that conference. It was actually in Chicago. And I learned.
Okay, Ishwish or John Ishwish?
No, it was not an Ishwish thing.
Okay.
And so I brought all that information back with me. I could help my patients with all things sexual. And I did that in a community hospital for 6 years or so. And then I went to the University of Missouri, Columbia. I went back to academics. And there is where I found Ishwish. I took the Ishwish courses. I did a preceptorship. I did my certification. No, I did Michael Critchman, Dr.
Michael. Great.
Yeah. So I shadowed him for a while in Laguna Beach.
Yeah.
And I did his course to become a certified sexual counselor.
Yeah.
And as you can imagine, there's a lot of crossover between sexual function and menopause.
Sure.
Then I found myself treating more and more perimenopausal and menopausal women. And so same thing, you don't really learn that in your residency and training. I found the North American Menopause Society, went to their conferences, became certified in menopause. And then the last thing that I did was the obesity medicine part, because as you can imagine, so many peri and postmenopausal women struggle with weight gain. So that was sort of the last piece that I brought in, took the courses, became board certified, and I practice obesity medicine as well.
Amazing. Yeah, we talked about that because I'm in the process of doing that right now, but
Yeah.
have the same sort of trajectory. And I think, like, actually talking to a patient for the first time that has a problem and
Good.
realizing, like, "Oh, crap, I don't know how to treat this," and, like, you can
Mhm.
research the hell out of it, but going to the people and the experts who are actually, like, writing, all the guidelines and all the things is where you have to go, and that's what you and I both did, and now many years in, I think we're both, this is our happy spot.
It's my happy spot. Yes,
Yeah.
I'm with you on that one.
Yeah, absolutely. Well, let's talk about I want to talk to you a little bit about obesity, drugs too,
Sure.
because that's something so interesting. But, the last time, I mean, obviously, I heard you speak in Dubai. We both were there for the ISSM. But previous to that, when the Ishwish conference was in St. Louis, you presented a lot of awesome research on sex and drugs. My
Mhm.
podcast is Sex, Drugs, and Hormones. So you check off all the boxes.
I know. I never set out to be the sex doctor or the drug doctor, but that it up. I mean, I had to explain that to my children. They think, "Oh, my mom's kinda cool." But
Right.
but yeah. So
Tell us what brought you into cannabis and the research because there's
yeah.
a lot of data suggesting. I think I read an article sometime last year that, like, I think it was like upwards of 70% of perimenopausal women who were using cannabis were getting relief of perimenopausal symptoms.
Mhm.
Maybe like 40% were turning to cannabis for some of their symptoms. So,
Mhm.
but I can't remember if that's exactly right. But it's growing that, because so many states have it legal now. But
Right.
tell me what brought you in because you're doing a lot of research on it and how
Yeah.
it's beneficial.
So it sort of fell into my lap when I moved to St. Louis and I was at St. Louis University. I had a very busy sexual medicine practice,
Mhm.
and a lot of women would come to me and say, I have low libido, I can't reach orgasm unless I use cannabis. Then it's all fixed. What do you think about this? And so, being the academic physician that I am, I'm like, well, what does the evidence show? So I went to the literature, published, medical studies, and there was very limited data about, obviously, because cannabis has been illegal until, recently, there just wasn't a lot of good data. So I set out to get some data myself with one of my partners at SLU, and we designed a questionnaire asking women, how was the sexual experience, libido, overall sexual experience, orgasm, and lubrication when they used cannabis. And we overwhelmingly found a positive association. So the majority of women reported overall the sexual experience was better, more libido, better orgasm. It really, in this sample of patients that we didn't affect lubrication. And I think we had over 200 patients, so it was one of the bigger questionnaires out there. Um, and we published that. And as you can imagine, because it's sex and drugs, it got a lot of press. Everybody wanted to, hear about it. And then we went on to publish just a review of the literature. And since then, now in Missouri, cannabis is legal, both medicinal and recreational. So things have really changed over the past couple years. But it sort of just fell into my lap, and the research fell out of a question that I was like, well, what does the data show? Well, we really don't have a lot of data. And the
Right.
data is not great because it's just based on recall and it's just a questionnaire. It's not
Right.
like you
That's
can
the whole
say,
point.
I'm going to give you cannabis and give this person a placebo and, see what happens. So, but it's better than no data.
No data, yeah. And I think it's interesting because there's so many different types of plants-derived cannabis you can like with
Yeah.
THC, with do you wanna speak to, like, the endocannabinoid system and why we think that, like, there might be, some changes? Because I always talk about the brain as a big sexual organ and
Yeah.
how it's, manifesting a desire based on, your neurotransmitters and hormones and all the
Mhm.
things. But
Yeah.
maybe just explaining, like, because a lot of people don't even know we have our own sort of endocannabinoid
Yes.
system and how that works on our system.
Yeah. Yeah. So there is an endocannabinoid system throughout the entire body. So you have receptors for your own natural endocannabinoids, but those are the receptors that cannabis, an external cannabinoid, binds to. They're in your brain. They're all throughout your reproductive tract. They're all throughout your body. And we didn't really know about this system until somebody was trying to, like a couple years, not a couple years ago, so many years ago, where scientists knew the effects of cannabis, but they were working on figuring out what receptors it binds to. And the scientists discovered this whole endocannabinoid system, and it plays a role in so many different bodily functions, and especially in the reproductive tract. So, we think of cannabis affecting your brain, but actually, there's some data to show that it helps with menstrual cramps because the uterus is chock full of endocannabinoid receptors, and that cannabis can help with pain and neuropathic pain. There's actually good data to support that. So it's everywhere. It's
Sure.
ubiquitous.
Yeah, it's ubiquitous. So, and it's interesting because most people don't even understand that we have this receptivity to it throughout our tissues, and that's why you see so many different like arousal gels and all the things that have like cannabis or THC or
Mhm.
that kind of thing. Do you I think the hard part is the lack of sort of regulation around like what's going into what in a dispensary, right? Like
Yep.
we know there's medicinal purposes for cannabis and there has been for years. And it's just difficult because this is how I always talk to my patients about like compounded hormones. Like,
Mhm.
there's no like regulation. So it's like when you take a gummy and one tastes like candy and the other one knocks your ass out for the next day. And it's
Yep.
like there's no regulation in terms of what's going into it. So if you prescribe that for any purposes, or I
Yeah.
know this is sort of something you started retrospectively looking at, but when
Mhm.
you look at it and people ask you about it, well, how do you use it in your practice?
Yeah. So a couple things about cannabis in general. I mean, there's like over 100 cannabinoids that, can go into different formulations. And cannabis is a plant with made up of several cannabinoids, flavonoids, and terpenoids. And
Mhm.
so, when you go to a dispensary, you can pick this strain or that strain or this strain, and they're all a different constellation, of all these different cannabinoids. So I get asked often, well, what strain should I use? And
Right,
really, there's no data. There's
right,
nothing to
right.
say, oh, this one is good for sex, that one's not. So I think it's a lot of trial and error.
Mhm.
There's some things that people will tell you, like indica versus sativa. Indica is like in the couch, like calmer.
Yeah,
Sativa's more wake you up kind of
yeah,
thing.
yeah.
But really, there's so much inbreeding that a lot of strains are a combination of indica.
Right. How do you even get a pure sample, right?
Yeah, and so there's really like not I don't have any strain that I particularly recommend.
Mhm.
I feel like the good news is that because like in Missouri, we have dispensaries, at least it's somewhat regulated now. And so you can get a gummy and it'll be like, okay, 5 milligrams of THC and 5 milligrams of CBD, as opposed to buying something off the street where you have no idea what's in it or if anybody's added anything that should be
Yeah,
there. So
that's
it is a little bit more.
right.
Um, but you had asked like where I use it in my practice. The other place I use it is chronic pelvic pain.
Sure, for sure.
For sure, because I know you've seen probably so many women who really struggle with chronic pelvic pain, and sometimes there's not really a great answer for them. And so, for many of my patients, we'll do like so. If I'm going to do cannabis, I prefer the gummy route or a tincture route as opposed to vaping or smoking because that's not good for your lungs. But we'll use a combination of THC and CBD to deal with chronic pelvic pain. And it's basically what I do is I might start with a 1-to-1 ratio. The THC helps with pain and the CBD negates the high effect.
Right.
So like we'll start with a 1-to-1. If their pain isn't controlled, maybe we're going to go up on the THC and see how that goes. Or if we tried a 1-to-1 and they felt too high, then we might go up on the CBD. So I kind of use it that way.
Yeah, and I think that's an issue we all face when we talk about, chronic pain, sexual pain, and such with patients who may start out with one etiology, or that might be the center for their pain. And then once it gets centralized and the brain is sort of involved, the peripheral
Yeah.
sensitization. Do you want to speak to that a little bit? Like what that means when people have centralized pain versus
Sure. Yeah. I mean, and pain is so complex. So what central sensitization is where your brain has been hearing pain for so long, it almost rewires itself to hear pain louder.
Right.
And part of how your brain hears pain, there's, neurologic signals that go up your spinal cord into your brain. And then your brain sends descending signals down that are inhibitory. So that way you can sort of blunt how bad that pain is. But central sensitization is sort of the brain rewiring itself and it hears pain louder. And so sometimes, like even when whatever noxious stimuli is not there, your brain can be hearing pain.
Right.
Yeah.
And that's when if you're looking for like these FDA approved products, we try those neuropathic pain medications to see if we can calm that signal down. But I think to your point with the endocannabinoid system, that a lot of patients respond really well to cannabis.
Yeah. Yeah.
And that's
There's good data to support that it helps with neuropathic pain.
right. Well, in terms of routes, you said you usually prefer either tincture and versus like gummies. Can you talk a little bit about the absorption differences?
Yeah, yeah. So I try to avoid smoking or vaping because it's just bad for your lungs.
Mhm.
So you can either go a gummy route or a tincture, which is a little drop underneath your tongue. And it depends on how quickly you want that effect. So unfortunately, smoking and vaping is the fastest effect, but it's not good for your lungs. But a tincture is the next fastest effect, where it's just absorbed into the blood vessels under the tongue. So that's faster, as opposed to a gummy, which can take an hour, depending on what you've eaten, maybe even 2 hours before you'll notice an effect. So when it comes to a gummy, I'll always say you have to give it time, because sometimes people take a gummy and they're like, it's not working, so I'm going to take more. And then, an hour hits and they're just super high and paranoid and end up in the emergency room. And
Right.
that's not good either.
Yeah, absolutely. So you have to be cognizant of the route that you're using and how it quickly gets into your bloodstream
Yeah.
versus how it's metabolized. So I think that's really important to hear. And when it comes to like sexual stuff, like what do you feel about some of these inserts, the vaginal inserts? Because there's so many out there now and they're so
Yeah.
accessible. Where do you use those in your practice?
So I really haven't used them a whole bunch.
Yeah.
I know that they're out there, but I haven't really used them to enhance like the sexual experience.
Mhm.
Um, I did try for a while. See, before cannabis was legal recreational in Missouri, I had several patients try like topical CBD. And
Right.
I would say it helps 50% of the time, doesn't do anything 50% of the time. How much of that is placebo? How much is legit?
Right.
Who knows?
Right.
It makes biologic sense, because like CBD binds to the TRPV1 receptors, which I believe is the same thing that like capsaicin binds to, on the vulva. And so biologically it makes sense, but there's not really a whole bunch of data to support it. And what I found is for some women it would help with vulvar pain, and other women it just did nothing.
Yeah, that's kind of how I feel too. And we all have those patients who, you treat the hormones for hormonally mediated vestibulodynia, but they actually have neuropathic or nerve proliferation. And some of the treatments are a hard sell for patients. I mean, you can treat their pelvic floor,
Yeah.
talk about capsaicin with them, and they get a little bit like this, and then you talk about like the end game vestibulectomy, and then they're still a little bit hesitant
Yeah.
sometimes.
Yeah.
And so
I've
I
never done capsaicin with any of my patients. Have you? I'm too
I have, I
chicken.
have, I have actually a handful that it's usually when it's an acquired neuroproliferation. I feel
Yeah.
like you do the best. I mean, I think with congenital, you pretty much have to go to vestibulectomy at some point, but
Yeah.
it's just a matter of how you get there because, like, you have to meet the patient where they are, and if they're not ready to try, and the regimen for capsaicin, capsaicin is the active ingredient for hot peppers. For those of you who guys don't know what we're talking about, but it is used for like nerve related pain and so, because it binds to the same receptors that Dr. Lynn was talking about, and so it's supposed to reduce over time. And the way we do it is usually, 20 minutes. You have to get up to using 20 minutes a day on the vestibule that's already in pain, you know, and you have to use it for at least 12 weeks. But the process of getting to 20 minutes is always a challenge for patients.
Mhm.
But the ones that I have that have really stuck it out, like they have gotten, some significant improvement. It's just
Good.
say, like, whenever I offer it to patients and they hear about it and they're like, "Okay," then some
Ooh.
will actually try it. I think some of it's cultural, like, some of my patients who are, like, okay with hot peppers are like, "Maybe I'll try it," because they're not as afraid of it.
Mhm.
But I agree with you. I think those are the patients that I'm like, well, until we figure something out, you could try CBD oral at the vestibule or whatever to see if it helps. And I agree with you. Like for me, I've seen maybe 50-50. Like sometimes it helps, sometimes it doesn't. But again, it's
Yeah.
kind of more of a band-aid, right? So
Yep. Yep.
okay, awesome. So I think that's very interesting. And I'm glad that you did the research because like you said, there's not much out there. So I feel like
Yep.
someone had to ask the questions. And now
Yep.
you're Becky Lynn, the cannabis lady.
It cracks me up. I was so surprised at how much media attention it got. I wasn't really thinking that way or prepared
Right.
for that, but it was kind of fun.
It
I
was
do a lot of podcasts about it, and
Yeah.
yeah.
Okay. The other thing I heard you talk about, well, actually, in Dubai, you were talking sort of
Mhm.
about breast cancer survivorship. So that's one of your passion points too,
Yes.
and the use of hormones. And I've had many people talk. I've Dr. Corin men talk about actual systemic hormones after breast
Mhm.
cancer. We've talked about vaginal. Tell me, like your perspective, in terms of how you approach sexual and the wellness with the breast cancer survivors that you deal with.
Sure. Yeah. So I'm actually a breast cancer survivor myself. So I feel like I have a little bit of a unique perspective.
Wanted you to
What's that?
I didn't wanna say it until you
Oh no, that's okay. I'll tell anybody who asks me. I'm no problem with that. And as you know, breast cancer survivors, especially when you block all their hormones or take away their hormones, can have a lot of sexual side effects, namely painful sex due to, genitourinary syndrome of menopause, which is basically vaginal dryness due to lack of hormones, but also low libido. So I am a big proponent of low dose vaginal estrogen, low dose vaginal hormones, including intrarosa,
Wow.
for women with breast cancer
Mhm.
because they've never been shown to increase the risk of recurrence. And they do a world of good for the vagina, right? Like, so for your listeners, premenopausally, the vaginal tissue is thick and moist. It makes lubrication. It's got collagen and elastin. It stretches. And when you lose those hormones, it gets thin and dry. It doesn't lubricate. It doesn't stretch. And sex becomes painful. And I feel like for breast cancer survivors, you get the diagnosis. It's all about getting rid of the cancer. No one's going to talk to you about your sex life going forward, but it's really, really important. And low dose vaginal estrogen is minimally absorbed and, like I mentioned, doesn't really increase the risk of recurrence. So I'm a huge fan of that. When it comes to systemic hormones, um, I don't feel comfortable prescribing systemic hormones to someone with estrogen receptor positive breast cancer. Knowing what I know, and I've looked at some of the data, I'm personally still not comfortable
Yeah.
because I don't know. I feel like we're not there yet. I feel like so maybe, the pendulum is going to swing. And I don't know if Dr. Blooming's new book has come out yet. They said September.
I
Yeah.
got I'll have a copy, I'll give it
I need to get that book and I'm like looking forward to reading it. But
Yeah,
I don't think knowing what I know that I'm comfortable giving women with estrogen receptor positive breast cancer hormones.
right.
I'm
Yeah,
not comfortable taking them myself.
yeah, so, and it would was yours before did you have it before menopause or
Yeah, so I was 39.
oh, or okay.
Yeah, so then that I was on tamoxifen for a while, then I had my ovaries removed, and so I was on a aromatase inhibitor for a while. That was the worst medicine ever, so I went back to tamoxifen. But I've basically been menopausal since I was 39.
Oh, gotcha, yeah.
Yeah.
So I think that's the question that, a lot of in the book Estrogen Matters, he addresses a lot of these issues about, estrogen and the use in breast cancer survivors that he's dealt with as an oncologist. So hopefully I'll have him on the podcast at some point. But
Yeah, yeah. I'm really interested in what he has to say. And,
there's some compelling arguments there.
yes, there are.
Yeah.
I heard him on a podcast. I can't remember whose podcast it was. I don't know. I'll have to try and remember.
Mhm.
But and there are some problems with the like the habits trial, which is the one that said you can never use estrogen in breast cancer survivors because it
Right.
increased the risk of recurrence. There's some methodological problems with the trial.
Yeah.
So,
Yeah.
who knows? Maybe 10 years from now things will be different,
Yeah.
but it remains to be seen.
Yeah, I will, if a patient, knows the data and understands the risks, and there's in certain amount of distress or concerned about,
Right.
cardiovascular brain stuff like that. we have a discussion around it, and then I'll, do it based, case by case basis. And,
Right, right.
some patients have had, I have a couple patients that you probably have the same that have had like mastectomies, they've had their ovaries out,
Mhm.
they've had all the things, and they're like, well, do I even need to see a gynecologist? I'm always like, yes, you still have a vagina, a vulva, a pelvic floor. We got to check everything, the
Yeah,
clitoris. But I think that, it's really a case by case basis for most people to
yeah.
evaluate it.
And it's a quality of life issue.
Right.
Like if you look at the risks and have all the information
Mhm.
and your quality of life is suffering enough, it might be worth it to you to take whatever risk is there. So,
Right.
it's definitely a case by case.
Yeah, or if you have like really strong cardiovascular risks and you go into menopause so early and you worry about like,
Yeah.
heart
Heart
disease
health.
that might still kill you before breast cancer. For a lot of
Yes.
you know.
Yeah. Number one killer of women for sure.
Mhm. Absolutely. Okay. Well, I'm glad you talked about that because that was my other aspect that I want to talk to you about. And then I do want to delve a little bit into obesity medicine because
Yeah.
we talked about it at Ishwish last time about how I've been using GLPs in my office, GLP-1s in my office for the last couple of years, and I started using them with PCOS patients.
Hmm.
And I realized that, some of them were struggling on metformin. They couldn't get rid of the visceral fat. But can we talk about a little bit in the midlife woman who is
Hmm.
suffering with so many issues around
Yep.
everything? But one of the number one complaints we always hear is like, I never gained weight in the midsection, and now all of a sudden I am. So if you can address that, like why that happens, and then
Yep.
let's talk a little bit about why, some of these medications are so remarkable.
Yeah. So a couple things happen to women in the perimenopause that contribute to weight gain. So one of them is loss of muscle mass. So every year, women will lose a little bit of muscle, and muscle burns more calories than fat at rest. So as you lose a little muscle, lose a little muscle, lose a little muscle, if you eat the same and exercise the same, your metabolic rate will be slower because you're less muscular. You'll gain a little, gain a little, gain a little, gain a little. And so what I hear in my practice, women are like, I haven't changed anything. I'm eating the same, exercising the same, and now I'm gaining weight.
Right.
And the thing with estrogen is estrogen improves how well your insulin works. Estrogen improves insulin sensitivity. So as estrogen levels are declining in the perimenopause and then really low in the postmenopause, the chance that a woman is going to be resistant goes up. And insulin resistance leads to weight gain. So what insulin resistance is, it's where your insulin's not working well. So your body has to pump out more insulin to get the same amount of glucose from the bloodstream into the cells to use for energy. And high levels of insulin is an anabolic hormone. It makes you deposit fat and it prevents the breakdown of fat for fuel. So the main thing, like one of the big take home messages about obesity is it's not all calories in, calories out. If only it were that simple. Absolutely not. So glucose metabolism, insulin plays a role. But as far as, women in midlife, loss of muscle and the increased chance of insulin resistance that are contributing to weight gain. And estrogen affects body composition. So when there's more estrogen around, you're more likely to deposit fat at your butt and your bust and your hips. And as those estrogen levels decline, it becomes more in the middle, your belly and visceral, which is a risk factor for metabolic disease. And so
Exactly.
that shows up around the time of menopause too. Like women who always had good cholesterol, all of a sudden they're like hit 50 and now their cholesterol goes up. And um, yeah, yeah, it's very frustrating.
I think that, it goes to show that, it's really a systemic issue. It's not just like you're losing reproductive capacity. And I think that for a lot of people who are, menopause is natural and all these things, of course, but it is something head to toe. We always talk about receptors from head to toe, and it really can impact your overall cardiovascular health, metabolic health, everything. So
Absolutely.
when you see these patients, tell me what you do for the workup. And well, let's talk about GLP-1s, for instance. They've been
Sure.
around for a long time, right? People have this misunderstanding that this is just a new trend, but I think it's just gotten a lot of traction because they work so well,
Mhm.
and Hollywood has picked up on that. So,
Yes. Yeah. Yeah, and so just to back up a little bit, I'm never I don't wanna I don't think it's right to say, "Here's your GLP-1,
yeah,
see you in a year." Like,
no,
losing weight and just, like, maintaining a healthy lifestyle is so important. So in my practice, I have 2 dietitians that I work with. We talk a lot about healthy eating, avoiding processed foods, limiting added sugar, cutting back on alcohol. That's another thing. Like the pandemic brought a lot of people into like drinking a lot of wine at night. Not good for you, not good for your weight. So we talk a lot about diet, what you're eating. We talk a lot about exercising and strength training, like building muscle. And then I do use GLP-1s. And GLP-1s, the way that I look at them, they are a game changer for people who have struggled with it. There are people, like it's in their genes. Everybody in their family has obesity. They exercise. They're trying so hard to eat right. They just can't lose weight. And we really do look at obesity as a chronic disease. So just like high blood pressure, if someone has high blood pressure, you put them on a medicine that brings their blood pressure down. You don't take them off the medicine because it'll just go right back up.
Yeah.
So, for many people, there's a role for GLP-1s and lifelong use of GLP-1s. And it's not a failure on your part if you need a GLP-1
There's
because
so much
they,
with GLP-1s, it's really, I mean, it's
yeah,
so surprising in the media, people, whatever, there's so
shot
much.
shaming.
Yes.
Yeah, you should not be shot shaming,
Yeah.
right?
Yeah.
And
Exactly.
the way that like the bigger picture, the way to look at it is like it's way better to be a healthy weight and
Right.
be on one medicine than
Right.
to have obesity and be on a medicine for your diabetes, your high cholesterol, your high blood pressure. Obesity puts you at higher risk for 14 cancers, including breast cancer, including uterine cancer. So if
Oh,
you need to be on one medicine, we should be grateful that we can help people maintain a healthy weight. And
right.
another thing that I think is super important that doesn't get enough traction, in my opinion, is self confidence and how you feel about yourself, right?
Mm.
So when you have obesity, you don't feel good in your clothes, that leads to depression. Like how you feel about yourself is so important. And I think it's just as important as avoiding chronic disease due to obesity.
Absolutely. And can you talk a little bit about how these medications work? Because, like I
Mhm.
said, they've been around, I think, for was it close to 20? I mean, I think the first oral one was what, 20 years ago or something like that?
I don't know. I know they've been around since for more than 10.
Yeah.
But they're
Okay.
not all super new.
Right.
So they work in 3 ways. So they go to your brain and they tell your brain you're full. So GLP is a hormone that our bodies make in our intestines when we eat food, travels to your brain and says, hey, you're full. And that helps you stop eating. But it's got a really short half life. So the GLP-1 agonists act like GLP, but they stick around for a long time. So they help with satiety. They also slow down how quickly food leaves your stomach, so you feel full longer. And then they keep your glucose and insulin levels in check, which is why they're also diabetes drugs. So they work in those 3 ways.
And I think what's interesting is that, the the feeling that you're talking about where you're full sooner, that whole satiety feeling is that food noise that people feel, right, in their
Right.
brain. And so
Yeah.
that's what I feel like people say the most is like, oh, the food noise has really calmed down.
Yeah, it's gone. Or like people will forget to eat,
Yeah.
or they go out to dinner and they look at a menu and nothing looks good.
Right.
So it really does remove, we're so naturally built, evolutionarily, it makes sense to want to eat food. And then you give somebody a GLP-1 and people are like, I can't believe it. I went all day and I just totally forgot to eat. Or the food noise thing where like, it's always in the back of your mind. What am I going to eat next? Oh, I know there's a cookie in the pantry. Am I hungry? No, I'm not hungry, but I really want that cookie. It
Yeah.
just like for so many people wipes that out.
Right. And what's interesting is, and I'm sure you've seen this in your practice, but I think, there's going to probably, I think there's more research being done on this is it working, on your dopaminergic pathways? Because now I have patients who are like, these like religious shoppers who have no desire to shop. They come in like,
Yes.
and
Yeah.
like all their like, habits that, gamblers who stop gambling, like there's some
Drinkers,
drink.
alcohol. It
Yeah.
makes people not want to drink. They lose the craving for alcohol.
Right. So I think that's going to be probably the next level of even looking at it. Like, is this something we can use for smoking cessation or other things that
Right.
might be helpful? But what's interesting to me, and this will you'll find. I'm going to be presenting this case at the conference in Rio. Well, not presenting it, but where it's a poster. But
Mhm.
it's interesting to me too that these GLP-1s, the way they act on your brain, like when you think about sexual function, what's happening. And so I've had some patients that have some persistent genital arousal disorder. I have this one case of a patient who really, in perimenopause had increased anxiety, all these things, gained weight. And, her treatment was it was a very long process of getting her there, which, included, CBT therapy. It included sex therapy, included pelvic floor therapy, included, hormonal optimization. But eventually, like what shut down her like final PGAD symptoms were going on GLPs. She went on a
Really?
Isn't that crazy?
Oh my gosh. Because I feel like PGAD is the hardest thing to treat.
It's
I have
so
several patients. We try this, we try that, and
Yeah,
nothing works.
nothing works. Yeah.
So now that I've heard that,
Yeah.
I'm going to put that on my
Especially
list of things to try.
right. I mean, because I think I spoke to a couple other sex med docs too, and they were like, one or two of them had also said they had tried it with patients who have obesity or, some
Mhm.
other thing that it actually then turned it off for them, which is interesting. Like,
Wow.
the dopamine is settling down or,
Mhm.
what is happening there. But, it's something potentially worth trying on patients who have other comorbidities.
Yeah. Yeah. And
So,
honestly, the way I look at that, like if you discuss the risks and benefits, like what is the harm in trying it if there's a chance it's going to help somebody's PGAD?
right,
You have to be careful if someone's really thin. We don't want to take away their desire to eat.
right.
But PGAD is so tough. Like
It's
there's just nothing that always works.
right. And
It's
I've
so
had
life altering.
Yeah, but when you have that persistent genital arousal or that genital pelvic, abnormal pain sensation,
Yeah.
it's life altering for people for sure.
Yeah. It's horrible.
Yeah, and so that's you'll see that poster at Maria that we're presenting, but it was really interesting actually. But I think that also just looking, does it affect sexual function? I know I want to say it was like Andrew Goldstein who made a comment at the last Ishwish conference about it and
Mhm.
whether or not we should look at how does it affect libido? How does it affect or because if your drive to do other things are going down, is your
Mhm.
libido going down? And I think I could see it both ways, right? Because if someone
Yep.
is obese and then all of a sudden doesn't feel good about themselves,
Mhm.
like, what do you think?
Yeah, no, I think it could go both ways. Like maybe it'll lower our craving for sex, but sex is so complex, desire is so complex. If you lose weight and you feel better about your body, that's
Right,
going to improve your libido.
right,
So who knows which route is going to have the bigger effect, the bigger magnitude effect. Who knows?
right. And I think both of us practice really precision medicine, so we don't cookie cut anything into one
Mhm.
patient, another patient. So it's a lot of times it's trial and error. It's like
Yep.
let's see what works for you. I mean, let's see what we know that with hormones sometimes we do that as well.
Yes.
We do it better with a patch or a gel or oral or whatever the case may be. But it has to really fit you and your lifestyle and what you can take, and sometimes what insurance covers.
Yeah. Yeah.
What do you what's your how do you like in terms because that's another big issue with the GLP-1s that we're trying to get FDA approved coverage
Mhm.
for these medications and using the ones that can be covered by your insurance.
Mhm.
So I think it's gotten better from what I've seen.
Mhm.
But
Yeah.
what do you tell your patients or listeners
Yeah.
about compounded versus FDA?
Yeah. So I don't use compounded. I think I have like a few people are doing it at their own risk, right?
Yes.
Like the FDA has recommended against compounding. So I try my darndest to use regular FDA approved. You know what you're getting. There's
Yes.
a lot of craziness out there on the internet. I would never just buy my semaglutide from some random internet site. I
Yes.
think that's dangerous. So
Right.
I'm like 99% of the time just do FDA approved.
Mhm.
Um, I personally I tend to choose Zepbound before I choose Wegovy.
Yeah.
There's no head-to-head trials, but just from experience, I found that people tolerate it, and at least in my practice, I think that people tolerate Zepbound a little bit better and
Mhm.
have more weight loss. But I have plenty of patients on Wegovy and it works great. And
Right.
sometimes insurance will cover Wegovy and not Zepbound, or it'll cover Zepbound and not Wegovy.
Yeah.
We do, we'll typically call it in, we'll do the prior authorization.
Every one of them needs a product.
Oh, everyone. Yeah,
Yeah,
they'll never just cover it.
yeah,
Whatever data they need, we'll send them the records,
right,
beg them to cover it, and
yeah,
sometimes it gets covered, sometimes it doesn't.
right.
I do have many patients who pay out of pocket,
Mhm,
and it's really expensive. It's, like 575 for Zepbound per month. So what we'll do sometimes to defray that cost, and there's no studies to support this, but to save money, we'll try and go every 10 days.
Yeah.
or every 14 days, especially when they hit maintenance. So that's one of the things that I've done to kind of bring the cost down. But this week, I've learned that there are now, maybe you know this, going to be vials of Zepbound.
Yes.
Where like the 2.5 dose is going to be 300 and something dollars. But
Right.
the 5 milligram dose, I can't remember exactly. It's going to be more in the, I think, 400 or 500 range.
Right.
But our rep is going to come talk to us about how that's going to work. So that, I mean, every dollar that you can save is helpful. So I'm kind of excited about these vials as opposed to the pen.
Right. And probably a little more environmentally friendly as well.
Yes, a lot more.
I think, and I think that's an important point to make because now, I mean, I feel like when insurances, when they were first getting really popular, it was like thousands of dollars to pay for Ozempic or Wegovy. Now Zepbound has been around for about a year or so, right?
A
Um,
little over.
a little over a year.
Percentage.
So I think that it's important to note that nowadays you can actually, and it's still a lot of money, $500 to $600, but that's what a lot of these compounded places are charging too. So like, if you can get the FDA approved medication, you're not going to like be, for the most part, you're not going to be like spending a lot more for the FDA approved stuff versus
Yeah.
from what I've seen. I've taken some patients off of compounding when they realize that
Yeah.
the cost is almost
Yeah.
similar to.
I would never pay that much for compounded. It's not safer. It's not better at all.
Right.
So
Exactly.
FDA approved is the way to go because you know what you're getting. It's regulated. You know it's safe. You know it's effective.
Right.
You know what's in it.
And I think both of us probably get why it exists the same way we know why hormone compounding exists because there was such a, like for at least with hormones, like nobody was getting hormones. So this industry came out and, has really been
Fill the
thriving.
void.
Yeah. And then I think that's why the compounding is existed too, because, getting the FDA approved products, number one, they weren't able to keep up with supplies, right?
Yep. There were shortages.
Yeah. The shortages and then the cost and everything like that at some point. But I think I think they're finally kind of catching up now. So that's good.
Yep. Yeah. Yeah. We haven't had a problem getting different doses like we did for a while. I think in the
Last year,
springtime
like,
it was
Jake,
tough.
yeah, it was really hard.
Yeah. People would either have to go up or down because they couldn't get the dose that they needed. So,
Right. And then
but we haven't had that problem lately.
oh, good.
Yeah.
Yeah, I think it's gotten a lot better. So I think that, trying to find someone from obesity medicine or, is going to be really important for getting the right type of overall care. Because you're right, it's just not give you the shot and go. You have to still
Mhm.
amount of protein. Like, what kind of stuff do you tell your patients?
Yeah. So
Um,
protein is super key. So I tell women at a minimum 100 grams of protein a day. So approximately like 30 grams a meal.
Yep.
You need your protein. Otherwise, when you break down fat for fuel, you're going to break down fat, but you're going to break down muscle. And that's going to slow your metabolic rate. So,
right.
two things to maintain your metabolism: strength training and getting enough protein in your diet.
Hmm.
Otherwise, your metabolic rate's going to slow down anyway because of metabolic adaptation, which
Hmm.
means your body senses that it's a little bit starving. So it's going to become more efficient. You'll burn fewer calories just living. So that's going to happen anytime you diet. But what you can change is not you can prevent losing muscle mass with eating enough protein and strength training. So pretty much 100 grams a day, at least 30 grams in a meal. And protein controls satiety too. So it really helps you feel full. So I'm all about the protein.
Okay. And I think that's important too, because I think that's something that, you hear about a lot of the negative information around some of these drugs is, oh, it's going to cause me to lose my muscle. And they're not muscle wasting drugs.
Nope, they're not. You just have to work out. And I feel like sometimes people get these and they're so effective that they don't have to eat right and they don't have to work out.
Yes.
That's when you lose muscle mass and it doesn't look good. It's not
Yep.
good. You need your muscle to keep your bones strong. Muscle is the key to longevity,
Right.
so they can be utilized in an incorrect way.
Right. Exactly. That's where they talk about that. Remember that there was a lot online for a while about Ozempic face.
Yep. Mhm.
That's not a thing. It's just you lost weight in
You
the
just
wrong.
lost weight. It's not
Yeah.
Ozempic. Yeah.
Yeah.
Same with hair loss.
Oh,
So
yeah.
when you restrict calories, it's stressful. And
Right.
stress, you're going to lose hair. So people are like, does Zepbound cause hair loss? No, weight loss causes hair loss.
Right. Exactly.
Yeah.
Yeah. I mean, I tell patients that, well, at some point you do have to choose between your ass and your face, you know?
Yep. Yep.
Like, dude, when you lose weight in your face, it
Yep.
does you look a little older. Like, it's
Yeah.
fine. When
Yeah.
you have,
And
you
and that's, I don't know if you see this in your practice, but because my practice is mostly like for women in their 40s and 50s, they'll lose weight in their face. And sometimes women are like, well, I want to be what I was when I was a teenager. And
yeah,
when you're 50,
yeah,
you get so gaunt. It is
right,
not the same. So
right.
we talk about what is a good healthy weight and what looks good.
Yeah.
But I
And not
sometimes feel
losing
like,
it fast, right?
and not what?
Losing it too fast.
Yeah, yeah. But I feel like sometimes we have to, set good expectations. And I do think like trying to be what you were when you were 16 is usually doesn't look good when you're 50.
Exactly.
Yeah,
And
not
also,
at
like,
all.
it's the same thing, like, with bounce back culture. It's like you have to start, aging in a way that you feel confident in yourself, but also, you're probably never gonna get back to that point, like,
No,
which is okay,
there's
like,
no need to be back at that point.
right.
It doesn't look good. It's not
Nope.
healthy.
Yeah,
So we
exactly.
just need to get that out of our minds. Oh, well, I used to weigh this. You just want to find a weight where you feel good, you look good. Just don't compare to what it was like way back when. Find a new happy place.
Right, exactly. And I think that's what you and I both try to do is like, as both as OBGYNs, we both went through a period where we're saving lives and delivering babies and, ectopic pregnancies and all that stuff. And so sometimes my colleagues ask me, like, don't you miss like being in the OR saving those lives? And I'm like, well,
Right.
now I'm about like really improving the quality of someone's life,
Mhm.
right? Like making them
Yeah.
feel a better version of themselves. Cause I think that is
Yes.
also a way to save someone's, like,
Absolutely. I totally agree with that 100%. And that's what I love what I do
exactly.
because I can really help people.
Last question, Becky. What about like what advice do you give people? Because obviously we all know, and we hear we hear the stories from our patients every day. Like I saw 7 doctors before getting this help. I saw this and that. I always have to ask like, what's your advice on how best a patient can advocate for themselves or find the best help they need in sexual medicine concerns or
Mhm.
menopause concerns or any of it?
Yeah. So I think this is a really good question because our healthcare system is a little bit of a mess.
Hmm.
So in traditional healthcare, you get about 5 minutes with your doctor, maybe seven, and that's not enough to go through risk, benefits, side effects of hormones or to discuss low libido, which is super complex. And so I feel like a lot of women will go to their regular physician who may not have training because it's not part of the standard training. Or so they ask a question and they get an answer. Oh, well, you're just getting older, which that just
Yeah,
drives me crazy because
right.
that's not the right answer.
Fine, and it'll go away.
Oh, yeah, that's like the worst
Like,
wine is definitely not the answer.
yeah,
So, what I and the other thing that I think people don't realize is when you go for your annual, insurance will not let you address a problem as well. So if you're there for your annual and you're like, by the way, I have low libido, your doctor's not going to address it. And then you're going to feel gaslit
yes,
because they didn't address it. It's not their fault. It's because
yeah,
insurance won't cover it, which is just highly unfortunate.
yeah,
So when it comes to menopause and sexual health, I think finding a practitioner who has extra training in this is the way to go, who's going to take the time to talk to you about it. So I always refer or to talk to my patients about going to like menopause.org, which is the Menopause Society website, which is excellent, evidence based, good information. And then they have a list of members of the Menopause Society and then a list of those that are certified. So they really did the test and the training and the continuing medical education. And same with ISWISH. So ISWISH has a list of providers. If you're looking for help with sexual issues, if you go to your regular standard OBGYN, like they're just not going to know.
mm,
And I don't fault the OBGYNs because like I don't do robotic hysterectomies. So someone might come to me and be like, tell me about a robotic hysterectomy because you're a gynecologist. And I'm going to be like,
uh, I
I
can't.
know nothing. So, medicine is so highly specialized. It's important so you don't feel gaslit. So it doesn't take you 7 doctors to go to a place like iswish.org or menopause.org.
Absolutely. I always say the system is set up for women to fail, right? Because
Yes.
like the system is an insurance-based system where the bulk of the money is based on the numbers that you see and the
Yep.
reimbursement is crap. And so any system that is based on that Really, I mean, you and I both been in academics where we had to see 30 patients a day or,
Yeah.
just to, meet
Wasn't
the quota.
feasible.
It's not feasible.
Nope.
Then as a
Not
result,
good care.
yeah, and then the physician gets burned out. Like,
Mhm.
I mean, I know you could probably relate to this. Like, I think back to like when I first started and, being in the academic centers and how there might have been that patient as you're leaving the door said, "Well, what about my sexual pain?" And you just were like,
Mhm.
you don't have time to
Can't be
address
done. You don't have time.
how to address it. Like, I feel bad retrospectively thinking about those patients that I
Yeah.
couldn't, because the system is rigged against us. The other part of the
Yes.
system is we don't get the training. So that's
Yeah, yeah.
yeah.
I can tell you that the day that I decided that I was leaving academic medicine and I was going to open a concierge practice was a
Mhm.
day that I saw a pelvic pain patient, and I was so behind because you get, double booked, triple booked, like, I was so behind, and I did the best I could in the shortest amount of time, and I walked out of the room, and I'm like, "That is not fair. I did
Yeah.
not do my best by this
No.
patient."
Yeah.
I felt horrible. So I called her at the end of the day and
Yeah.
finished out the visit. But I was like,
Yeah.
I have to leave this system because it's
Yes.
important to me to provide the highest quality care. And you can't
Right.
do that in a 5 or 7 minute visit.
Right. I think you and I both go home at night. Like, I was the same way. I would be like, God, I just didn't do that patient the service she needed, and
Yep.
it eats
Mhm.
you up actually.
It does. It
So,
does. Because we want it. We want to help. That's why we're here.
right.
So, yeah.
Well, thank you so much, Dr. Becky Lynn. You're amazing. I love everything that you say and do. So I'm excited. I'm excited to see you, well, next couple weeks in the menopause
Yeah.
conference and again in Rio. So we'll have a
Yep.
couple of, coffee sessions and talk a little more. But anyway, thanks for joining me today. My name is Dr. Smeenerman. This is Gyno Girl Presents Sex, Drugs, and Hormones. I'm here to educate so you can advocate for yourself. Please join me next week for my next episode.
Thank
If you
you
have a
for
second, please subscribe to this podcast. I'd love for you to be a follower and learn as much as you can about the things that we're going to talk about with all the people on our journey. Please review us on Apple or Spotify or wherever you listen to podcasts. These reviews really help. Review us, comment, tell me what else you want to hear to get more information. My practice website is www.cgcchicago.com. My website for Gyno Girl is www.gynogirltv.com. My Instagram is Gyno Girl, so please follow me for some good content. Additionally, I have a YouTube channel, Gyno Girl TV, where I love to talk about all these things on YouTube. And please subscribe to my newsletter, Gyno Girl News, which will be available on my website. I will see you next time.